Morning, everyone. Oh, we have a nice little group. Okay. Sorry I was a little late, but it's nice to be here in person. And I think we have a first-time speaker in Carlos today, so this will be really exciting. No pressure. So this is Carlos Saldaña. He's a postdoctoral fellow at the HNRC at UCSD. He's currently aiming to acquire new skills at the intersection of HIV prevention, substance use, and unstable housing homelessness. Until now, his work has focused on applying statistical and mathematical modeling methods to understand the impact of repeated incarceration on injecting risks and hepatitis C transmission among people who inject drugs. Before joining UCSD as a doctoral student, he worked as a community outreach worker at the Boston Healthcare for the homeless program as part of a primary care team, assisting providers and helping patients address the social factors impacting their health outcomes. We are very lucky to have you here and very excited.
Thanks so much for the introduction, Jill.
Good to see you.
Hi, everyone.
Hi.
Thanks for joining us this morning. So like Jill said, my name is Carlos Rivera Saldaña. I'm a postdoctoral fellow. And today I'm going to present work entitled Modeling the Contribution of Incarceration and Public Health-Oriented Drug Law Reform to Hepatitis C Transmission and Elimination among people who inject drugs in Tijuana, Mexico. So this is today's presentation is about work that I mostly developed during my doctoral training at the intersection of hepatitis C, incarceration, and people who inject drugs in Tijuana between 2018 and 2022. It was published between 2021 and 2023. And like Jill said in the introduction, I'm also presently exploring a new intersection, which is HIV prevention, substance use, and homelessness. And I have no conflicts to disclose. So first, I'm going to start with some background on why hepatitis C is a global health concern. And here when I was developing this work, this is the background that I was using, but then which comes from estimates from 2015, a publication from the Polaris Observatory that was published in 2017. But then I was doing some digging this week, and I realized that like at the time when I was getting my works published, there were some newer estimates from the same group that were published in 2022, and these estimates are from 2020. So actually they are comparing what happened over those 5 years. So I thought it was interesting, instead of showing one or the other, I thought it was interesting to see what happened over the course of those 5 years. So the number of adults living worldwide with hepatitis C went from 71 million in 2015 to 50 million in 2020. With an estimated 400,000 annual deaths, hepatitis C-related deaths worldwide, it went to 300,000. And around that time, around the 2020, like 80% of the burden of hepatitis C was said to be concentrated in low and middle income countries. And now that burden went to 70%. So, I mean, like, just as the authors note, it's good to see some decreases, but the burden is still high, and this is still a global health concern. So, and just if anybody is curious about those references, there's where I got these new estimates, updated estimates of the burden. And I know a lot of people here have clinical background, so no, I'm not gonna get a lot into that, but so hepatitis C is primarily transmitted by injection drug use in developed countries, and in developing countries is still transmitted by unsafe medical procedures. So upon infection, 60-25% of individuals transition to chronic liver disease, from which 10 to 20% advance to cirrhosis, with a 3 to 6% annual risk of hepatic decompensation, and a 1 to 5% annual risk of hepatocellular carcinoma, with 15 to 20% risk of death. It's also important to note that the chronic infection may be like 20 to 30 years when an individual may have the chronic infection showing no symptoms. But the good news was that around probably like a decade ago, and probably people here have a more accurate year, but around a decade ago, the development of second generation direct acting antivirals that had more than 90% cure rates, as well as other benefits, like I think less side effects and working on different hepatitis C genotypes as opposed to a few. This was a great development that prompted the World Health Organization to set global targets of hepatitis C elimination by the year 2030. And these targets consisted of an 80% reduction in hepatitis C transmission and a 65% reduction in mortality. However, as some publications were noted, there were some countries, probably Canada, a few European countries, and probably Japan, that were on track to meet these goals. But what those studies said, they suggested that what they were doing is, they were capturing the lower hanging fruits, which is people that were connected to healthcare, that had access, that were utilizing, that were engaged with healthcare. And so there are still a lot of challenges ahead and to meet this elimination target, which is the date is coming fast. So there's several challenges, but one of the challenge that is right now of interest for this presentation are high risk populations that are harder to reach. So we know that injection drug use is the main route of hepatitis C transmission, and that makes people who inject drugs a key risk population. So transmission mainly occurs through the sharing of needles and syringes, and also injection equipment. And global estimates have the global estimates suggest that around 67% of people who inject drugs have a history of hepatitis C infection, which is around 10 million individuals. There's other studies that suggest that there's like 6 million individuals, like people who were engaged in recent injection drug use that are currently living with hepatitis C. Among people who inject drugs, unfortunately, criminalization and punitive policing are very common, and these two things have been associated with injecting risks and a bunch of different adverse health outcomes, such as bloodborne infections and drug overdoses. For example, like concerns about arrests or syringe confiscation normally disrupt safe injecting practices. Also, this population face disproportionate higher rates of incarceration and reincarceration. And the incarceration continuum, which is defined by detention, incarceration, and the period after release, has been identified as a period with elevated injecting risks. Why? Because there's also disruption of harm reduction services and disruption of social networks. And for those individuals, even when some individuals stop injecting or inject with less frequency inside prison, the used needles and syringes may be shared like much more often, so increasing the risks of infection. A systematic review and meta-analysis found that among people who inject drugs, recent incarceration was associated with an 81% increase in HIV acquisition risk and a 62% increase in hepatitis C acquisition risk, and that this risk persisted after incarceration. However, when we were developing this work, the long-term cumulative effect of incarceration on injecting risk remain unknown. So this is one of the gaps that we wanted to address in the analysis that I'm gonna show later. What is this cumulative effect of repeated incarceration? So first, when people start learning that the punitive policing and criminalization are not producing the expected effect, what are people doing about this, right? They're actually increasing some health risks instead of decreasing. So there's the concept of public health oriented drug law reform that includes decriminalization. And some international examples have shown that this may help to reduce risks of bloodborne infections through reducing the risks associated to incarceration, but also makes the encounters with law enforcement an opportunity to divert people to harm reduction and treatment instead of punishing. So following some of these international examples, in 2009, Mexico enacted a drug and health law reform called the Narcomenudeo Reform, which consisted of deregulating possession of small amounts of selected drugs and mandated treatment upon reoffending instead of reincarceration. However, a mathematical modeling study, actually spearheaded by Annick, found that there was that, and another body of literature found that the impact was not as high as expected, mainly because practices on the ground were not changing, like policing practices or incarceration rates were not changing. So while the impact on HIV was studied, we did not know much about how, if implemented properly, would the Narcomenudeo Reform impact the hepatitis C epidemic among people who inject drugs in Tijuana. So this takes us to a couple of analyses that we did to try to understand some of these features. So the study setting is, like I said, is Tijuana, Mexico, which is a city located in a major drug route to the US. And so the northern Mexican states like Baja California are places that have the highest prevalence of drug use, especially injection drug use. Like inside the country, especially like a decade ago, like injection drug use was not a big an issue, like was negligible. Only like a few spots, probably like associated to tourism, something like that, but it was not a big issue. But the northern towns, the northern border is. People who inject drugs in Tijuana are at high risk of bloodborne infections due to several reasons, but one of them is that in general in Tijuana, vulnerable populations have very limited access to harm reduction, treatment, and even basic healthcare. So with this background in mind, our first objective was to assess the impact of cumulative incarceration on syringe sharing, which is the main route for hepatitis C infection. So the previous literature had established the link between between incarceration and syringe sharing. However, the cumulative long-term effect of repeated incarceration and the post-release period had not been measured. So we aim to address this gap. So we used that data from a cohort study that I think finished like a couple of years ago. Which is a PWID study. It's a community-based cohort of people who inject drugs in Tijuana. Participants were recruited between 2011 and 2012 with 6 months follow-up. For our longitudinal analysis, we consider a follow-up of 10 visits, which was approximately 4.5 years. We managed to define a subsample of people who inject drugs that had not reported a history of incarceration at baseline. And this was good because we were ascertaining our exposure prospectively, as opposed to having people that would be bringing already certain risks that we could not control or measure. Also, as people may know, these cohort studies have a lot of loss to follow-up. So individuals that intermittently come and go, or people who permanently leave the study. So we used a probabilistic method called multiple imputation by chain equation to bring those individuals who had left the study back into our statistical process. And we use a package called MICE in R with the same name. We performed, so the analysis was a logistic regression. We generalized estimating equations. These equations are normally used. So when you're measuring the same individuals over different time periods, those observations are correlated because it's the same people. So the GE structure controls for that kind of correlation. Our outcome is receptive syringe sharing measured in the previous 6 months, and it's a binary outcome. And our main exposures were cumulative incarceration, which was pretty much aggregating the number of incarceration events that individuals reported over the follow-up. And we also designed like a post-release period variable, which is mainly just counting the time after one incarceration event occurred. What was the time that elapsed after that? And we put these two variables, we made some categories for them, as you will see in a future slide. The covariates that we used for control to control in our model were factors that were associated with syringe sharing, drug use, and injecting behaviors among people who inject drugs in Tijuana from previous published literature. So what did we see? So it was interesting that out of the 734, 185 participants met our inclusion criteria of no history of incarceration at baseline. Also, an interesting feature was that 67% were female, which is not so common in cohorts of people who inject drugs. The median age was 35 years, and the median injection duration was 13 years. This plot shows the evolution of the missing data, so participants leaving the study constantly but permanently across all visits, the 10 visits. So, and it starts in the second visit with a 20% loss to follow-up, and it ends with a 40% loss to follow-up. That is substantial follow-up. So, I mean, the statistical literature said that you could be getting biased estimates if you don't do something about that, if you don't account for it or even talk about it, right? And assume what. So we used the method that I described before to incorporate all those individuals back to our study. So at baseline, 65% of our subsample had engaged in receptive syringe sharing in the previous 6 months. This is important to know for the second analysis, and we'll get back to this point, but we know that it was a common outcome as opposed to a rare one, like a lot of people were doing it. And also, like during follow-up after doing our imputation, 150 participants, which is approximately 80% of the subsample, reported a total of 358 incarceration events. People were normally incarcerated 2 times, and 25% of the sample reported more, only 5% of the sample reported more than 3 incarceration.
Hi, Davey.
With a maximum of 8 incarceration events. Probably at this point is worth knowing we're talking a bit quickly about my interpretation about this. So this kind of interaction is not so much individuals who are gonna be spending a long time in jail. It's more like this constant persisting policing that occurs, but more like low impact but persistent interaction with vulnerable communities. In this case, people who inject drugs in Tijuana. So I think it's more like that, like a bit of a catch release, something that in the US would be like jail time without sentencing. So normally like 3-4 days or less than a week, and people get, so that kind of policing, that's what probably like people should have in mind about this. I'm not gonna spend a lot of time in this analysis, so I'm going straight to the multivariable analysis. So we're trying to see, so our exposure, we're assessing our first exposure and how cumulative incarceration is associated with receptive syringe sharing. And so this is what I was talking about. So this variable, cumulative incarceration, was made with 4 categories. The reference categories is no incarceration, so people who have never been incarceration. Then we have 1 incarceration, 2 to 3, and more than 3 incarcerations. And we can clearly see how the odds of engaging in receptive syringe sharing increase as our number of cumulative incarcerations are increasing. We also ran a test with this variable, but not with categories, but using the continuous form. And here we found that every additional incarceration episode increased the odds of syringe sharing by 17%. Now we did exactly the same analysis, but now our exposure is post-release categories. So again, our reference category is no incarceration, so that those variables depart exactly from the same point. But now this one is, now we did categories for post-release. So the first one is individuals who were released in the past 6 months, then individuals who were released in the past 6 months to 1.5 years, and then in the past 1.5 years to 2.5 years, and then more than 2.5 years. Here, what we see, the result of interest is that, yeah, the odds remain high are high for individuals who were recently released. But also this elevated effect still persists 6 months to 1.5 years after release. So after, so there's like a lingering effect of incarceration on receptive syringe sharing. In a nutshell, we found that the elevated risk observed among recently released people who inject drugs persists after 6 months after release. So some of the pearls about this analysis is that we were able to define a subsample with no history of incarceration at study entry. The way we were happy with the way we handled the missing data. There's an important limitation that we did not incorporate the time spent in custody. And some of the reasons I already explained before, but it was not very well, it was not assessed with precision. The answers of participants were not very consistent, but in general, it referred to shorter, to detention, to a few days and a week. Only some people reported like 6 months or 3 months. So it was not long sentences. The key takeaway of this analysis is that the effects of incarceration on injecting risks are cumulative and persist in the post-release period. This analysis was published in the journal Addiction. So now, we're going to the mathematical model. So just a little recap. The narcomenudeo reform sought to deregulate possession of selected drugs and mandated treatment instead of incarceration upon reoffense. However, previous studies found that the narcomenudeo reform had not the expected impacts on HIV transmission, but the impact of the reform on hepatitis C transmission had not been studied. So we aim to investigate this impact. So for this purpose, we developed a dynamic deterministic model of incarceration, hepatitis C transmission, and disease progression among people who inject drugs, which was also stratified by incarceration history, so frequency and recency, and also opioid agonist therapy status. Individuals could be in and out of harm reduction. This schematic depicts the model. So individuals enter the model as new injection drug users, new persons who inject drugs enter the model, not infected, not engaged in any hepatitis C treatment, and not engaged in any harm reduction. And upon infection, those who do not clear the infection advance to chronic infection, and if left untreated, might progress to different liver disease stages like compensated cirrhosis, decompensated cirrhosis, and hepatocellular carcinoma. Individuals can be treated, and if they achieve sustained virological response, they're gonna go back to being susceptible. However, if they had advanced to these disease stages, they're still gonna remain in the same disease stage. So somebody with compensated cirrhosis, even if not infected, is still gonna have compensated cirrhosis. And also people who was cured can become reinfected. Also, in our model, people can move in and out of OAT. And those who are enrolled in OAT experience a 50% less, the risk of hepatitis C transmission is decreased by 50% because they are in opioid agonist therapy. So what did we use this model for? We used this model to assess, well, we actually did three things, but these are the main two. We used this model to assess the contribution of incarceration to hepatitis C epidemic among people who inject drugs in Tijuana. In other words, we estimated the population attributable fraction, which is defined as the proportion of disease that would be removed, the proportion of disease that would be removed if you remove a risk factor from the population. Right, so if we're removing incarceration from the population, how would that look like in terms of new hepatitis C transmission? And we also we also used this model to project and assess changes in hepatitis C transmission under different decriminalization, harm reduction, and treatment scenarios to try to recreate what would have happened if the narcomenudeo reform in Mexico had been properly implemented. To inform this model, we use parameters from previous statistical and modeling studies among people who inject drugs in Tijuana. And for the hepatitis C transmission and disease progression parameters, we used established literature on the subject. Also, and we simulated a population of 10,000 people who inject drugs in Tijuana based on earlier literature. And we also introduced elevated risk of hepatitis C transmission through syringe sharing that were specific to incarceration history. And think about the previous statistical analysis that I presented. These elevated risks were calculated in a very similar manner. The only difference is that in the previous analysis, we used odds ratio. And when you have an outcome that it's rare, relative risks and odds ratio are the same or very similar. But when your outcome is very common, the odds ratio overestimates. So we want to use relative risks for our model. And the way we introduced this elevated risk was through a little incarceration and reincarceration submodel, where our never incarcerated individuals that are entering in our study, let's start moving to one incarceration. Some people get reincarcerated, so a second incarceration, third, and more than three. And also people are recently incarcerated or non-recently incarcerated. And each of these compartments is associated to an elevated risk of acquiring hepatitis C. And finally, we calibrated the model to a 67% chronic prevalence of hepatitis C among PWID in Tijuana, which is high, but that was based also on some previous work. So the scenarios that we explored with this model are, first, we did a baseline scenario, so a status quo. How would think the business as usual? You maintain the same rates of incarceration and reincarceration. People are not engaged with treatment or OAT. So we just want to see how the model works under the status quo levels. Then moving away from baseline, our next scenario is we remove all elevated risks associated with incarceration to estimate the 10-year population attributable fraction between 2022 and 2032. And then we considered three different decriminalization scenarios. One where people, the first one is only decriminalization, so no other thing, just decriminalization. And it consisted of an 80% reduction in incarceration and reincarceration rates. And then a fully implemented drug law reform scenario that, besides decriminalization, also considered that individuals would be diverted to opioid agonist therapy. And then finally, a scenario where, what if we have that fully implemented drug law reform and we also added hepatitis C treatment treating 500 PWIDs per year. So what did we see? Our status quo projections show that among those 10,000 PWIDs in Tijuana, by 2022, which is the start of our analysis, we had 6,700 chronic infections, an incidence of 21 new infections per 100 person years, which corresponds to 700 new infections. And also by 2022, in our model, 55% of individuals had already experienced at least one incarceration event, and a few others had like 2 and 3 incarceration events. So for the first, for one of our first analysis, which is estimating the 10-year population attributable fraction, our model projections suggest that the 10-year path of incarceration to hepatitis C incidence is 5%. So in other words, this means that the elevated risks associated to incarceration contribute to 5% of incidence hepatitis C infections. This is equivalent to 400 newly infected PWIDs. We also tried a different thing here, like an alternative thing, which was removing not all the risks, but only the elevated risks associated to non-recent incarceration. And we found that that corresponded to a 4%, that corresponds to a 4%. So pretty much the greater portion of all the incarceration risks corresponds to non-recent incarceration. So to that lingering effect that stays over time among individuals. Those are again the population attributable fractions for each situation. And now, what did we see when we introduced our scenarios for drug law reform? So the first, if we only introduce decriminalization, again, which is an 80% reduction in incarceration, we would see a 5% reduction in hepatitis C incidence. If we introduce a fully implemented drug law reform that also diverts individuals to harm reduction, we would see an 11% reduction in hepatitis C transmission. And finally, if we add and we deploy treatments, you would see like the greater reduction with 40% of reduction in hepatitis C incidence. We also thought things a bit differently. So we'll, like the 2030 deadline to meet the WHO targets is coming fast. So we also thought, how many treatments would be needed, or how can we achieve this 80% reduction in hepatitis C incidence with the tools we have? What combinations are gonna make this happen? So first, it's worth noting that without hepatitis C treatment, according to our model, we would not reach the target. However, we found out that if we only deploy treatment, the direct antivirals, we would need to treat 1,400 individuals per year. If the treatment was combined with decriminalization, the number of treatments required would be reduced in 4%. And if you combine treatment with a fully implemented drug law reform, the treatment requires would be reduced by 14%. So I think here, I'm gonna step a bit to just talk about this and see how we're looking at it. So even if the reductions in treatments are not super huge, they are meaningful. Because in middle income countries or low income countries, treatments are expensive. And also it's important to show that in order to achieve elimination, you need a synergy. You need to take advantage of synergies between, it's like a multi-pronged approach where you need to have your treatment, but also you need other policies and interventions that complement the efforts. And I think this is the value of this study, that it shows how these synergies could work. So in a nutshell, our projections suggest that incarceration is associated with a 5% of new hepatitis C infections among people who inject drugs in Tijuana. The full implementation of public health-oriented drug law reforms in Mexico could reduce hepatitis C incidence among people who inject drugs by 11%. And also, this full implementation could help reduce a bit the number of hepatitis C treatment required to achieve Mexico's elimination goals by 2030, saving 200 treatments per year, which this could mean the decision for some government entities to say, okay, let's go for it. Let's do the multi-pronged approach. Let's get a specific number of treatments, but let's combine it with other policies and interventions. And so some of the features of this analysis was that we were able to inform our mathematical model with data from an ongoing cohort study. And the key takeaway is that incarceration is a driver of hepatitis C transmission among people who inject drugs in Tijuana, and substantial gains can be achieved from fully implementing drug policy reform. This paper was published in the International Journal of Drug Policy in 2022. And before I finish, I wanted to leave some thoughts, kind of like the reflections about this work. So pretty much what we sought was to broaden the knowledge of the harmful effects of policing and incarceration on the health of people who inject drugs, and to investigate how drug law reform can improve health outcomes among people who inject drugs. The statistical analysis adds to the literature by identifying a risk profile of people who inject drugs in Tijuana experiencing this repeated, constant incarceration that are more likely to engage in injecting risks. And this new understanding underlies the need to reduce encounters with law enforcement. But if these encounters occur, probably favor a harm reduction approach instead of reincarceration. So return. Also, our model projections offer new evidence to rethink about the public health benefits of comprehensively implementing drug law reform by showing how we can reduce hepatitis C transmission. This is important. So partial approaches, such as those usually implemented after the narco-menudeo reform, so only decriminalizing, may not take advantage of the synergistical effects of fully implementing diversion to harm reduction and also the treatment. So in Mexico, so this narco-menudeo reform was implemented in 2009 at the end of one administration. This was the administration that engaged in a frontal combat with drug cartels, and they saw, oh, things are not going the way we were expecting. So I think this is this reform was one of the policies that they enacted to trying to counteract some of the negative effects that were seen after the first approach. And however, the reform did not garner like national attention. Like the states had to pass like health law reforms, criminal system law reforms, and so only a handful of states actually enacted the required reforms to be able to implement the policy. One of them was Baja California, and apparently they started enacting the reform, but nationally, no. I mean, like it was just a few states, and then in the subsequent administration, the topic was dropped. Nobody else picked that up. Nobody else used like up to now, actually, nobody else like proposed a comprehensive public health-based approach to deal with the challenges related to drug consumption in Mexico. And so that's an important point. So it's a topic that it's still very relevant. Some limitations in our study was that for the statistical analysis, we were not able to determine causality. And also we did not consider the effects of the COVID pandemic, which could have changed a lot of things, patterns of incarceration. We don't know if if prisons were overpopulated, so they stopped incarcerating people, or if they were incarcerating more people to keep certain people, to keep people out of the streets. We don't know how that went in Tijuana. It could have gone either way. We also know the impact on injecting behaviors or how police encounters may have changed. And also, this model could also incorporate additional health outcomes where we can explore, like much more robust impact over the health of people who inject drugs. And for this analysis, I want to acknowledge the the superb guidance from doctors Natasha Martin and Javier Cepeda, and all my co-authors and contributors that helped with great feedback and also editing and guidance with the studies. Thank you.
Thank you so much. That was, oh, no, you can hear, I'm sorry, I'm muted here, but there is a question from Dr. Richard Garfien. Richard, you can just unmute yourself and talk.
Okay, great. I was trying to turn on my camera, but I guess I'm black today. Carlos, that was a really wonderful presentation. Thank you so much. And I think you've done a wonderful job of making very good use of the data from the El Coyote study. I know it's complicated, but you did a nice job and made a very compelling case for a harm reduction approach to preventing Hep C in the region. I have two questions or things that I'm wondering if you've considered. The first is, I really appreciated in your first paper where you not only looked at the increased incidence of syringe sharing associated with incarceration, but then what we rarely see when we're looking for causality is when you take away the exposure, do you see a decrease in the incidence? And you showed that in your analysis, which I thought was really nice. My question for that part, and I have two questions. So my first question is, there's still sort of a question of causality. Was the incarceration what led people to share syringes, or was it that the people that are typically going to share syringes anyway, the ones that are getting incarcerated? It's still a little bit fuzzy there. So I think maybe some qualitative interviews or something to get at what's going on. Were they sharing because they were in prison and they couldn't get a syringe, and that's why they're reporting more sharing, something like that. So that was my first question. So hopefully you can remember that, because I'm going to ask the second one. The second one is the use of opioid substitution therapy to prevent transmission of HCV makes perfect sense. I completely agree with it. However, there's been sort of a shift, I know maybe more in San Diego than in Tijuana, from opioids to methamphetamine injecting, which could reduce the impact of opioid substitution therapy. Did you consider that, and how do you think that would affect your recommendations? I think that might be a question that could come up when you're trying to, argue for this model. So thank you again, and thanks for answering my questions.
Thanks so much, Richard. Those are great questions. I think for the first time, that is a very good question. And I think we did have the limitation that we were not able to see what's going on inside prisons. And I think that it's, I think there's been a few publications, and I'm trying to remember, that looked into that. But there's not a lot of work inside prison, so we actually don't know what you were saying. We don't know what was first. So I think what you say, qualitative interviews, probably to try to learn more of what happens, what goes on inside prisons would be great. I don't know how easy that information is.
How would you do that?
Exactly. That.
Yeah. Well, I think you could do that for people after they get out. I wouldn't do that while they're in prison, but maybe afterwards, go back and say, what was going on? Why were you sharing?
Right.
There are some studies that managed to, I don't know if in the US, but I think in Norway, there was a study who managed to do some qualitative work inside, inside the prison. But yeah, probably recently released individuals would be great to answer some of these questions to understand what is going on with that risk. And yeah, and for the second question, I'm not sure what has been the trajectory of methamphetamine in Tijuana. That's something that I need to update, because there's also less data. But I mean, Tijuana follows, as you probably know, it kind of mimics some of the trends that happen on this side of the border. So I would say that probably as time goes by, the MAT, the medication assisted therapy for methamphetamine, is going to become much more relevant also in Tijuana.
Carlos, so what's your thinking? It's kind of like the chicken or the egg. You have these people being incarcerated and they may potentially increase their exposure to hepatitis or it may be the other way. The reason for them to be incarcerated is because they were using injections.
Yes.
So I don't know if you guys consider to check on what were the reasons for incarceration, even just catch and release in Tijuana.
So I think what happens, what previous literature has found, and this is a really great question, because yeah, so this is among people who are already injecting. So that population is already at risk of hepatitis C or other bloodborne infections. But these policing events, such as not just incarceration, also arrests, patting down, the constant policing has been associated with disruption of safe injecting practices. So probably some people who inject drugs are already at risk, but they are probably practicing some safer injection by carrying clean syringes or by injecting in certain places that where they feel safe. But with the policing practices, sometimes this becomes disrupted. So people stop carrying clean syringes, they start sharing more. They do rushed injection, which that has also been associated with elevated risks. So yeah, so we're departing from a population that has some initial risks, but we think that these exposures to policing and incarceration elevate the risk additionally. That by that also, after release, some other studies have found that people, so individuals who were previously engaged with social services, right, harm reduction services, treatment, after the incarceration or after these encounters with police, when they feel they have to move to a different area of the city because it's not safe anymore, they disrupt their engagement with services also. So, and this is very relevant actually now to the next topic that I'm trying to work on, which is also related to homelessness. Now that there are some laws that are being passed that are banning encampments, and so there's the question of, are people gonna be moved further away from the services that they were already engaged with? And is that gonna increase risks? So I think that's the kind of like the way that we're looking at this elevated risk.
And also a follow-up question. I remember a few years working with the Comité Binacional de Tijuana.
Okay.
They were experiencing raids being done at the Borgo, right, where people were at the River Canal, where people would hang out and use drugs. And then they were being sent to other places of Baja California, not knowing where to get resources, where to get treatment, and then trying to figure out their way back. And they were, many times, that's the only place they knew where to live and get cared for.
Exactly.
Is that still happening?
That's a great example. I'm not sure if currently, but the PWID team worked a lot on that kind of events. Yes. So that's a great example. They were raiding El Bordo. People got dispersed in the city or even in other places. And so the services that were already targeting individuals who were living in El Bordo or that were within reach for individuals in El Bordo were not any longer available. And that also puts people at risk of different things, right? So yes, I want to say that there was a recent one within the last year, but I'm not super updated about that. But yes, that's like an on and off situation. So yeah.
I have a little comment. Thank you for your talk. It was excellent. I know in your last few slides, you're talking about this multi-pronged approach. And have you thought about also adding like hepatitis B, looking at hepatitis B, especially in this people who inject drug population, and and certainly HIV you had on your slide as well too. And from a multi-pronged approach, even considering adding PrEP along with drug treatment, et cetera, because, for people who inject drugs, it's really those three infections. Yeah, perhaps looking at that in a combined approach would be interesting.
Absolutely. I think, yeah, that is a great suggestion. And and one of my interests now is actually to look more to understand more PrEP and barriers to PrEP among some vulnerable populations. So it would, yes, definitely, I think that the synergies between as many interventions and as many different combinations are the key here, right? I think, I don't know if there's one single approach that can be like the silver bullet. So yeah, definitely addressing hepatitis B and also HIV within the same and PrEP and introducing PrEP within the same strategy would, I guess, yeah, that would be great. And it would be great to study that to see how the results would change.
Anik has a question, which may be the last one, we'll see.
Well, it's not so much a question. I'm going back to the whole discussion on causality, and it's more of a comment saying that what Carlos did with his statistical analysis was actually a great improvement from what we had done before, just comparing people never incarcerated with past incarcerated, because he's showing a dose response, which is one of the tenets of causality, but also focusing on only those who had never been incarcerated. So it was already a big improvement, and I think something that could be done would be to restrict the analysis to those who were never incarcerated at the beginning, but who end up being incarcerated eventually, so that we're not comparing against those who never become incarcerated over the course of the study. But the sample size is relatively small, so I'm not sure that would be doable. So that potentially is a question for you, Carlos. Do you think that would be feasible to just exclude from the analysis those who, over the time of the study, actually never got incarcerated? And then the second question I had in regards to that is that your sample was 67% of women, because most men were had already been incarcerated before, even before kind of joining the study, and even before starting injecting, if I remember well. So were you able to look at differences between men and women, or was there not enough power? And do you think there might be differences? You know, the fact that for the mathematical modeling, you're applying these relative risks that mostly represent women. Do you think that could be an issue?
Yeah, no, these are good questions, and thanks, Anik, and also for the previous explanation. Yeah, that's something we're considering, that addition to the literature by doing the analysis the way we did it. I think to answer your first question, I don't know. I don't know if excluding the people who were never incarcerated would actually tell us, provide us stronger evidence for the receptive syringe sharing. I'm not sure. I need to think about that. And for the case of the women, yeah, no, you're right. So there were power issues. We could not stratify anymore.
Mm-hmm.
So already that we were working with a very limited self-sample. So we were like borderlining not being able to do it. I do think there were, I'm trying to remember what were the differences between the groups, but yeah, there were some differences. And so we did try to stratify, we did try to assess some things by gender, but yeah, for them, especially for the, but we lost power. So yeah, the elevated risks are reflecting more the characteristics of the female population. Probably also more prevalent sex work could be adding to those elevated risks. However, I don't know if in the male population there might be other things that could also be compensating for that. But it would be really interesting to follow up on your comment and kind of look into that, see how that works.
Thanks, Carlos. And the other thing I was going to say is that there was some literature from the El Cohete study, maybe a previous El Cohete cohort, from Robin Paulini, asking about sharing practices inside prison. And what she found was that a small proportion continue injecting in prison. So in a way, there's a reduction in risk when entering prison because many people stop. But for those who continue injecting in prison, there's a highly elevated risk of sharing because there's no available syringes. I did some qualitative work with previously incarcerated participants who have been incarcerated in the past 6 months. We didn't focus on the risks of syringe sharing upon release, but basically for those who have been incarcerated for a very long time, there seems to be a period in which they continue not to use and eventually often relapse. But for those who are incarcerated for a very short amount of time, they come out with very severe withdrawal and they just kind of use whatever they can as fast as possible. And that generally is associated with syringe sharing. There's also loss of network, loss of housing, employment. I mean, so I think the literature has shown generally and for Tijuana that incarceration is associated with higher risk of risky injecting practices. But yeah, I agree with everybody's comments that it'd be nice to do a very specific study looking at that.
Absolutely. Thanks so much for your comments on it. Yes, Paulini, yeah, Robin Paulini's study, actually, it's one of the early references that depicted what happened inside prisons, yeah. Yeah, so there is work inside the prisons.
Not easy though. Well, thank you. I think that was the last question and we're right up at time, so
Thanks for having me.
thank you for coming. You know, you're gonna be invited back. You have a water?
Oh, yes, okay. I'm gonna get you one of our fancy high run water upstairs.
Oh, perfect.
It's lovely. Did anyone, no one has it. Okay.
Thanks so
Bye,
much,
everybody.
Thank you.